All right. Welcome, everyone. Good afternoon for many of us, and good morning for many of us as well. I'm Joshua Chodos, and we are very excited to bring you what is the first in a series of webinars on early detection of dementia from our CDC Public Health Center of Excellence. This is led by myself and by Dr. Sue Borson, who you're going to hear from in just a few minutes. And I suspect many of you are familiar with the work of our center, but for those who have not interacted with us, please indulge me for just a few minutes. So our center interacts with state, county, and city departments of health, community organizations, and health systems from all over the country, learning from all of you so that we can share it with others through events like this, as well as through our website resources and other large meetings and many technical assistance calls. We offer expertise in the mechanics of dementia detection, what the tests mean and don't necessarily mean, and what considerations are needed if planning to initiate a detection practice, alternatives to screening that reflect the problem more deeply, and the many clinical wraparound issues worth considering. Perhaps most importantly, we have lived experience as dementia detectors ourselves as clinicians, and the sensitivities we have acquired or captured in our CDC branded detection toolkit, for example. So we have lived experience through these deep collaborations with others who have implemented detection and diagnosis programs. And we have implementation expertise as well that respect and embrace the local organic focus of any successful implementation effort. This has an important evidence base that we're eager to share. And we're excited to have all of you join us this afternoon. I just want to make sure you all know that this presentation will be recorded. So thank you so much, everyone, for being here. And I want to turn things over now to Dr. Borson.
Hi, everyone. We're proud to present our inaugural webinar on improving dementia detection in healthcare systems. Our guests today are two expert geriatricians from the University of California. In addition to their outstanding academic credentials and creativity, both are active clinicians who have special expertise in dementia. Both are experienced educators committed to making sure that education goes beyond academia to benefit the care of patients in the community. Each has created a novel approach to improving dementia detection, establishing care pathways, and improving geriatrics training, and both have substantial leadership roles within their respective healthcare systems. Their dedication and many accomplishments are detailed in their bios for you to review at leisure. But let me highlight just a couple. Dr. Chodos is Associate Professor of Medicine at UC San Francisco. She's Principal Investigator of Dementia Care Aware, a statewide initiative sponsored by the California State Department of Public Health. Dementia Care Aware aims to prepare primary care clinicians for detecting and managing older people insured by Medicaid but not eligible for Medicare due to factors such as immigration or work history. Her clinical work focuses on the care of underserved older adults in the safety net and adult primary care. Dr. Lisa Gibbs is professor and interim chair of the Department of Family Medicine at University of California, Irvine, and founded the program on geriatric care principles with a particular emphasis on social determinants of health. She has held key leadership roles in geriatrics education and clinical care, health administration, and has become a force for improving aging and healthcare experience in Orange County. So let's get started. Josh, you want to start us off? With questions? Questions.
Oh, I was muted.
Yeah.
So which of our panelists is going first today?
Either way, I'm happy to.
Okay.
So what exactly have you done? I mean, so let's focus on early detection and how that links up to clinical care. So that would be our first question.
Well, I might start by just reviewing, as a geriatrician, what we've noticed and what our patients and families present to us with. I think the argument for early detection and the argument for raising awareness in primary care is a strong one because as geriatricians, we know that patients and families and caregivers often come to us with symptoms that are confusing to them. They may not understand why their family members no longer able to keep up with their daily life, activities of daily living, or, especially instrumental activities of daily living, and why they're becoming so isolated. So sometimes dementia gets so far down the road that, all of a sudden people find themselves in a crisis. And sometimes as geriatricians, that's how patients come to us. And we realize that, they've been through a significant period of confusion and suffering and really misunderstanding. So I think, as specialists, we know that there are very few geriatricians. We will not have enough. We're already facing that situation with primary care as well. But it behooves us to really raise awareness and train for early detection with primary care doctors who can then do the best by their patients, work on prevention, work on training patients and caregivers, what the community resources are and so forth. I'll just stop there, but I think the need we see in geriatrics, that really what we need to do is build that foundation in primary care so patients are detected a lot earlier and they don't have to go through this period of confusion and suffering.
Thank you for that. And Dr. Chodos.
Yeah, that was really well said. And I think hopefully really resonates with people who are in primary care or in other ways advocating for better care for older adults in primary care. Also, I just want to make one quick clarification. The Dementia Care Aware program, we are heavily bolstered, supported, and I think given a good megaphone with the Department of Public Health in California, but it's really a Department of Healthcare Services program, which is Medi-Cal. And I think the wonderful thing about that, and essentially I really see us as realizing their vision for the idea of more early detection, especially in the Medi-Cal or low income population of older adults. In a way they connected it for us. They said, in California, this is a priority. This is really important. Older adults, especially those that we serve in healthcare settings that serve Medi-Cal patients, this is, a priority now, and we're going to put an investment to it. And so for me, the way partly it links to clinical care is just that there's political will or healthcare system reform will behind it. I think as a clinician, the other thing I would add to what Dr. Gibbs said, which is so true, that many of my colleagues in primary care, myself included, just tend to see this when it's really symptomatic. We see dementia when it's really symptomatic. I also want to quote a social worker at the Rancho Research Institute and the California Alzheimer's Disease Center in LA County, Joseph Herrera, who always says, it's really the behavioral symptoms that we see bringing people to primary care. And I think that really resonates with me as a consultant trying to help primary care. Behavioral symptoms are a major, major factor in terms of, bringing this issue to consciousness for everybody, really creating a management challenge. I think in primary care, we also see that we're not well equipped from an office setting to necessarily perfectly manage behavioral symptoms. And, that is a caregiver intervention in a lot of ways. If that caregiver is present, it's, optimizing all other aspects of healthcare. So we need to harness that. We need to harness the fact that primary care providers, families, people living with dementia, when they see these symptoms, they're kind of ready to deal with dementia and to have a diagnosis, to hear that something is going on, that there's an explanation. But I think in trying to make the argument for why early detection is so important, we do want to connect it to that. We don't necessarily always have to be living in those moments. We could be providing people with an earlier diagnosis, tools to address that. And this just so hits home with two patients I saw last week. You could not believe how similar their situations were. Same neighborhood, same racial ethnic background, same family dynamic of a woman who is the patient, an older woman, and a caregiver who was their only child. And both in really different situations. One who had no clue what was going on, could not understand why their parent was acting like this, couldn't get their act together. It was stressing them out like you would not believe. And another one who we had diagnosed 5-6 years earlier when she was really coming in with other symptoms and had all the anticipatory guidance in the world. And he was calm as a cucumber, even though his mom was, really having a lot of behavioral symptoms. And we were at a new stage, a new phase of her condition. And so, right then, and I had a medical student with me, it was completely perfect in terms of illustrating the point that when someone has 5-6 years lead up to that moment, they're in a completely different place emotionally. It was taking a totally different toll on him than it was on the other child, the daughter, who was like completely upset and overwhelmed, understandably so, and needed really more of a crisis intervention. Adult Protective Services is involved. The building managers have been involved. There's all sorts of additional drama. I think, however, we still need to really make the case and tie it to all other aspects of older adult well-being, healthcare, brain. We say a lot in dementia care aware, and I would love to hear the audience's thoughts and your guys' thoughts on, is this really whole person health? The argument we make is this: there's no way that a degenerative condition of the brain is not going to affect all other aspects of that person's health and ability to self-manage and the resources they're going to need. And so we really want to tie it to the incredible passion, commitment, and skill that primary care has to take care of the whole person. And then finally, the only other thing I'll say is in clinical care, we want to know we're helping people, that what we're doing, all that lead time is to a benefit. And of course, reduce stress, better quality of life for the person living with dementia and their caregiver is crucial. But we actually know we can slow decline the earlier we detect. And I know that's the efforts of BOLD and the mission there as well is, there is so much to do. There's so much active to do if we have an earlier diagnosis that actually will slow that person's progression and improve their overall picture. And so we need to also, we beat the drum about that a lot in my healthcare system and also in dementia care aware. So I know that was a long answer, but it was such a good question. So thank you.
I want to pick out a couple of things from what you said, Dr. Chodos. One is in the beautifully contrasting cases that you mentioned. The first person, there are implications for what clinicians do, depending on the stage at which detection occurs, right? So with the cool as a cucumber caregiver who had 5 or 6 years of preparation, during that time, the clinician has the opportunity to prepare that individual for changes in behavior that are part and parcel of the dementia syndrome that don't always, different behavioral issues come up for different people, but in general, moderate and more severe dementia is associated with more problematic behaviors that challenge caregivers. So one of the conundrums here is convincing healthcare delivery systems that this is an important endeavor. So you mentioned that there are impacts of dementia on all aspects of care. And we know quite a bit about this from the standpoint of analysis of healthcare utilization. What do we know? We know that people with dementia, undiagnosed dementia, are likely to have more missed visits in ambulatory care. They miss more visits, no-shows. They have more hospitalizations. They may have more problems with misuse of medications, innocent misuse due to cognitive deficits. And the list goes on. And yet it's been difficult for many clinicians to convince their healthcare systems that an endeavor that focuses on early detection, let's call it, instead of early detection, planful detection or systematic detection, right? Kind of intentional detection and linkage of newly detected cases to care pathways that have both preventive and ameliorative benefits. Why is it so hard to get healthcare systems to pay attention to this? And what have the two of you done to influence your own delivery systems in a better direction? Let's start with you, Dr. Gibbs.
Hi, thank you. Yes, wonderful question. I believe we need to have geriatricians and like-minded folks in leadership positions in healthcare systems. I think if you're not used to treating dementia, if you haven't had a personal experience of dementia with family or friends, it is difficult to wrap your head around what it really is and the longitudinal devastation and progression that this causes. I think it's kind of like primary care. We save lives quietly and over a long period of time. We're not trauma surgeons, we're not cardiothoracic surgeons that will suddenly save you from a heart attack. And so it's nuanced. I think it's harder to convince people about, you know, conditions that are really nuanced and a little harder to wrap your head around. But in our health system, you know, early on when we decided to really to put an investment into population health, fortunately, I was able to be at the table and really argue that as a geriatrician, I understood how to take care of complex older adults. And that if we can devise our system or develop our system to take care of complex older adults, we can take care of anyone. So the rest will follow, right? And it's a team-based model, and it works. And we've had a senior health center here for many, many years, which proves that. From a population health perspective, it makes a lot of sense. Aside from all of the examples that you gave, we know that patients with and persons with dementia who are hospitalized with comorbid conditions, for instance, have longer lengths of stay. So, you know, not only do we want to prevent these admissions by preventing the missed appointments and the polypharmacy and all of that, but we'd like, you know, we'd like to be able to be preventative, so proactive, not reactive. So all of this means, again, that I think we need to develop our infrastructure of primary care, and then we need to make that infrastructure very aware of dementia. One of the ways we're tackling this here at UCI is through the annual wellness exam. And so I and a colleague, Dr. Tam, sort of redeveloped the annual wellness exam, integrated it into EPIC in such a way that it's very, very easy to do. And of course, the cognitive observation or evaluation is a part of that. So part of that is just to make it, you know, a part of something that's normal, right? We don't have to call this out. This is just a part of checking up and screening on your health and on many different levels. And in addition to that, as we developed our program, we brought on health coaches where we have in every primary care clinic. And one of their incentives is to sign people or schedule people and patients for annual wellness visits. So now we have an alignment with health coaches, you know, boots on the ground that will actually help people with their questionnaires and set them up for appointments. Now we have, you know, a set of clinicians that understand that it's going to be easy for them to do annual wellness visits. The reimbursement is great. I mean, it's equivalent really to a 99214. Makes sense. And so by virtue of doing that, not only have we screened everyone that has one, but we're also reviewing all their social determinants of health and whatever assistance they may need from community resources. So I'll stop there, but that's just one of the ways that we've really tried to bring this and make it mainstream in our system. And then finally, the other big point here is that once you find out that there may be some cognitive dysfunction, we can't just leave, you know, the primary care clinicians hanging, right? We need to make sure that there's a mechanism to refer to a health coach or a social worker or some community-based organization that can help these patients. So we can't ask the primary care clinician to diagnose cognitive dysfunction and then leave them with no tools from which to work. So the next step is then to provide all of these tools within the system or some way to refer patients to community resources. So I'll stop there. It's a long answer, but just a couple of ways that we're tackling that.
So the practicalities of that are something that I hope you'll come back to later in our conversation today, the actual how-tos, because what you've outlined is I think among dementia specialists like all of us on this on the screen today, what would be considered a best practice approach, right? A kind of proactive planful detection strategy using the wellness visit. And I understand you incentivized your clinicians to do them, by the way, and that they're not outsourced to a company that does annual wellness visits on the phone. They're actually part of the clinical care of the patients that you see in your clinics. Is that correct?
That's correct. I mean, and the physicians and the APPs are completing the annual wellness visits. which I like because I find for myself that it helps me know my patients better.
That's what the wellness visit was really designed to do, by the way.
Mhm.
For our
Yeah.
listeners, the wellness visit had as one of its primary motivating factors was to make sure that doctors and patients had time to talk to each other when
Mhm.
when the patient was not sick and didn't have another immediate need. It
Mhm.
was to really establish a preventive approach to care that set the stage as a perfect fit for detecting and managing cognitive impairment, by the way. I mean, it
And
was
Yeah.
Medicare
yeah,
was pretty smart about that.
and
Josh.
Sue, I would just add a perfect fit for primary care.
Mm-hmm.
Knowing your patient and what you've articulated, Dr. Gibbs, is something that it fits the spirit of the primary care clinician.
Mm-hmm.
And I saw you, Dr. Chodos, I saw you nodding your head a lot. So you must, I'd love to hear what your strategy has been.
Oh, absolutely. Yeah. I mean, just great points. And I hope, and I know one of the goals of this webinar is to give people practical tips. And I think I've, I can't particularly even say, Dr. Gibbs and UC Irvine, they've had tremendous success. Like their rates of doing annual wellness visits are really amazing and detecting cognitive impairment. We're still working on it and creating data infrastructure, but it was making me think of just all the practical aspects of this, sort of like any other initiative, any other goal or like population health goal you would have. So really non-specific to this issue things are, reading the culture, understanding the values that drive your organization. How do people talk about change? How does change actually occur? Like we have a lot of totally, I say this just from a practical standpoint, bureaucratic things we have to do to get change to happen. I agree with the leadership comment that I thought was brilliant is, can we be more intentional about getting age-friendly minded or, geriatrics trained folks in leadership that will clearly make a big difference. The other thing is maybe considering, I don't know how else to say this, like language, how we talk about these initiatives, because sometimes it really helps to just have a term, have an effort that we're going for. So not just we're going to improve rates of dementia screening, but we're going to use this to become an age-friendly health system. That there's something about that I think gets a little more traction in leadership and is one of, I think, the brilliant aspects of the age-friendly health system movement is it gives us that language to anchor and to promote. And of course, mentation and mind is part of that. I mean, the other one is the annual wellness visit. That's a concrete thing we have to accomplish. My system doesn't do the annual wellness visit. But I think I was just thinking of some of the practical aspects. And I think the other thing something you said, Dr. Chodos, was about primary care. This belongs with primary care. This belongs with primary care. Dr. Gibbs does primary care. I did primary care, and then I backed off to do more of the consultation and co-management work and dementia work. But that partnership and getting the language and the motivation and the goals from primary care fitting into the way things work in primary care, I think is really important because I think they hear a lot that everything is their issue, everything is on them. And then this issue of, okay, well, we're telling people to do early detection. We want them to screen, that we give them the tools for that. We're really clear about that. What's the what next? And I think we want to be really honest, practical, supportive about what's next and make that hyper local. And what I mean by that is, actually I was just trying to briefly read some of the Q&A and somebody pointed out, there may be some harms here. You may be labeling people or kind of setting them up to think they have something and then not really have a way to guide them through that. Somebody else mentioned the diagnose and adios problem, that once we do, screening and ultimately diagnosis, do we really have enough support for people? Being really thoughtful about that. Like if you're in a system that doesn't have social work, doesn't have healthcare navigators, what really is going to be the plan, and not to present people with a toolkit or a set of next steps that are unachievable. What is the right balance between detection, resource connection, early interventions in terms of hearing, vision, social engagement, physical activity, all the things that are pretty non-specific but very impactful. How do we make those seem doable while not asking people to do undoable things like get a bunch of imaging and labs and things if that's not a resource in that area, or connect to social work if that's not a thing. So I think just the hyper locality of it, like these changes, we're all going to reinvent the wheel to some degree on this issue and make it, you know, fit in the context and be styled in the context of where we're actually working. And that's, I think, just good practice change overall. The other thing somebody I work with also mentioned to me recently is, you know, we really need to build in small wins. So show that we have a goal and meet it. And so, you know, determining those things in a way that maybe this sounds like too contrived, but, you know, we want to set achievable goals and then win and then promote that. And that's one way also to show that, you know, we're really making an impact. So showing, and then I guess the last thing I'll say is data. You know, most places right now really do care about data and what you know about the status quo, what is the target, and doing that thoughtfully and getting partners in that. Like in my system, there's some tools that they give us to get our own data. And then there's some you really have to ask for and ask for help for from centralized IT teams, because they have a million initiatives going on. So they need to be thoughtful about that. So
I want to come back to this issue of team care, because I think you won't get any disagreement from probably anybody on this webinar today about the importance of team care. And yet the average primary care clinician does not have a team. You know, the team is pretty tiny, and there's usually not a social worker. There may not be a nurse, or there's a, you know, these are some of the issues that are structural determinants of whether or not a healthcare delivery system is able and willing to pick up on chronic problems like dementia, and to be planful and intentional about developing a program. So this is where the leadership issue comes in, getting a seat at the table to lobby for what we know we need to do in the care of people with dementia. It is a different challenge from most of the other chronic progressive diseases that affect other organs. I like to say it's because you can cope with almost any disability if your brain is not disabled. But once your brain is disabled, you can't cope with anything, let alone another disability or another medical problem. So when we have some comments in the chat here in the Q&A about a number of things like the skills that are involved in disclosing information about dementia. And there is, you know, I think we could spend an hour unpacking the terminology question. When do we want to say it's dementia, and when do we want to say something that is a lot less confrontational, such as, it seems that you have a bit of a problem with your memory, and that's something we should be paying attention to. And let's talk about what you know about that, what you're experiencing, what you know about it. And the you can be the person themselves, or the family member, ideally someone from the family or friendship network who knows the person really well. Because for most of what we can do to help people with dementia today, isn't it true that the most important thing is that they have cognitive impairment? Not that they have dementia as a label or Alzheimer's disease. You know, when we're talking primary care, we're talking about dealing with a problem that limits a person's autonomy. And that's what has so many implications for healthcare. Would either of you like to comment on how that translates into actual practice?
Well, I agree with you. I mean, once you put a label on something, sometimes it's a little harder to digest. What we really want to know is whether someone is safe, thriving, surviving, but thriving even, you know, living where they, in their choice of location, with the people that they want to be with. And how are they doing? You know, is that a challenge? If that's a challenge, how can we help them circumvent those challenges? So, whether the challenges are from cognition or, physical issues, is important, but in some ways what you're bringing up is, do we really need to call it dementia? Do we need to call it MCI? Do we call it cognitive dysfunction? Do we call it, the fact that, yes, there is something going on in your brain, which is making it a little more difficult for you to organize your life. And what can we do about that? And I agree with you, but also, you're bringing up, I think, the point of that relationship between the patient and the primary care clinician, which is so important, because you need to know your patient, you need to know what they're ready to hear, you need to know what they want to hear, what kind of support they have. And if you do have that relationship, it's really I think a lot easier, and much, much better. And right now, if primary care clinicians aren't used to detecting, talking about it and so forth, then their patients don't have that benefit of that relationship when they're going through that disclosure. So I don't know if I answered your question, Dr. Borzen, but that's what came to mind.
Right. So I want to kind of pick up on a couple of things there. So the way we talk to patients about their condition doesn't have to match exactly what we code in our diagnostic or the diagnostic labels we give through codes for Medicare claims.
Well,
and yet it is important to make a diagnosis from the standpoint of being able to acquire data about how you're doing as a healthcare system in managing patients with cognitive impairments. Yeah, you wanted to say something. Go ahead.
The only rub there, and I agree with you, the only rub is that, nowadays patients have access to their progress notes and so forth. And when we bill it, we may bill something that says dementia, and patients and families will see that. And sometimes they'll come back and they'll be fairly upset because, well, you didn't say I had dementia, but, you're writing that I have dementia. So, I think we have to be aware of that, because that can create problems, and maybe just, let them know that, they may see this word, but, this is how I have to communicate with your insurance company. I don't know, but I think we have to create that somehow.
There is more, and I want to turn to Josh for just a minute to talk about our CDC branded toolkit on early detection that is intended for generalist clinicians. Sure. Because go ahead, Josh, and talk about how
so
we address this issue of labeling.
I think certainly both Dr. Gibbs and Dr. Chodos have a lot of experience with this, and I would love to hear how you do this. But how we have approached this is really words always matter, right? And the words are out there, and sometimes patients come to us with those words before you mean you're talking about dementia, or you're talking about, they'll even say the word properly, you're talking about Alzheimer's disease, in being more specific about one form. And I think that what I hear both of you sort of moving towards is obviously where we're struggling a little bit is this issue of stigma. And this issue of the power of words and how it objectifies people in ways that none of us want to be objectified. We want to be human beings, and we want to have the value that we think we have for ourselves and others. And so I wonder what, I think certainly what we're doing in the BOLD Center is trying to develop and then provide the language for any clinician who is in that space of having to have these important conversations in a way that is more of an opener and putting it in its proper place. There's a word we use, it's called dementia. Have you ever heard that word? It's just a word. What we're really talking about is all of us, our brains and the processes that we go through in our brain. So this kind of more neutral, less calamitous, if you will, kind of objectifying language. But I wonder, I think that, and I want to respect what's happening in the chat here, because some of our primary care clinicians, I think, do an outstanding job with this. They don't need us to teach them how to talk to patients, and others probably benefit from that. But I do think one chat in particular from Patrick Zook was asking us about primary care clinicians, which I think everybody on this call holds in great esteem as the place where the business end of dementia detection and care. But if you have a primary care clinicians who only see a handful of dementia patients as part of their practice, how do we enable them to be more comprehensive, if you will, in dementia care? There's always that other process or possibility of the specialized centers of excellence, which we all know have tremendous access concerns, in addition to some other challenges. How do you put all this into perspective in your work in trying to make sure that patients who come to see primary care clinicians get the care that they need for this problem in a comprehensive way?
Can I sort of tie the issue of like how we're talking about this with patients to the issue of universalizing and standardizing the assessment? Because I think the other issue I just wanted to say about actually putting it in the chart is communication with colleagues, because we've all seen patients who've been in the hospital 4 times, it's dementia's all over, and but it's not actually on the problem list. It's never been coded except maybe some coder in the hospital for the inpatient stay. But it's not called out in a way that other providers will quickly see it. So there's like this sort of chart hygiene issue and shorthand communication among providers. And I think that's really important too, because sometimes you'll see somebody, they don't have a diagnosis, and you're like, how is this not in the chart somewhere? And you realize it's buried in notes, and that's just a lot of extra work that sometimes isn't going to happen. But Dr. Chodos, I've done a similar thing in my practice. It sounds like to what your toolkit recommends, or the language you give, which is I always ask sort of what they think is going on, what words they're putting on it. Do they think it's a problem? I just want to let you know, in terms of a medical condition, we call it this thing, dementia syndrome. That means this things, and I tie it to everything we've just done. We've talked to you for an hour about your symptoms. Obviously this is in a non-15-minute visit context, but or we've done over multiple visits, we've been talking about this thing. We got these labs, we got this imaging, and this is where we're at. What this really means is we're going to work together to support your brain to get the medications right, so you're not having more symptoms you don't need to. All the things about now, these are the implications and how we're going to support you. Does that sound good? Does that not sound good? I mean, and just the sort of cultural relevance of like, if someone really doesn't identify with the term, this is normal aging, we may have to sit in that place for a while and just they're going to conceptualize it or fit it in as it fits in. But we can still, I think, use terms and be clear about how we would categorize it as well. And I hope people in the chat have thoughts. I think that also, though, I hope brings it to a more manageable place and I always think of disclosure as like, we're doing it at a screening moment, we're doing it at a diagnostic moment, we're doing it kind of every time we see the person. I've had many people we've talked about it every visit, and they still don't know that they have dementia. They're not really picking up that word, and that's okay. I'm still proceeding with the same care plan of working on cognitive and functional symptoms and supporting them in those areas. But I think the thing that hopefully is more doable for primary care, for really approaching it from like a just tell the patient what you're seeing standpoint. Like, you're doing this workup, you've used these tools, just disclose, walk them through what you've learned in a way that allows them to have that information. I hope that that's more doable than like a specialist came and waved, a special reflex hammer, and now we know exactly what they have. It's like, it is achievable because we're doing these things. We can interpret these things. It's within our skill set. That's what the toolkits really give you, or short trainings that you can take to kind of learn, here's how I would do a quick screen, here's how I would do a longer diagnostic assessment. And the bottom line with how do we standardize this? How do we get people who mostly see women and children in a large community health network to like be able to do this with an older adult who pops in? Is just standardization. Like, there needs to be a standard approach. And that doesn't mean the exact same tool. That doesn't mean the exact same questions. That doesn't mean the exact same approach in every place, but it does mean that your clinic has a way that you approach it. The reason I say that is because we're all often seeing very different populations of people. And Dr. Borson has helped me come to terms with this and help me find a way to talk about it, but we don't have one tool that works for everybody. It's just, we don't, and we're not going to in terms of a cognitive assessment tool. We have to be thoughtful about matching the patient population with the tools. And that is work that needs to be done up front as you're creating this is what we do for all our 65 and older. We give them these vaccines, we do a quick brain health check, we screen them for dementia with this tool, we screen them for depression with this tool, we screen them for falls with this question. Like, this is how, and in my mind too, this is how hopefully we'll start to reach some of the really looming disparities in outcomes for folks, is equal opportunity to detection and access to a diagnosis earlier on.
So let's reflect for a moment on the fact that a dementia diagnosis is not usually an emergency. It is a process. And the process starts with having some kind of indication that there could be a problem. And that, as we know, can come from the patient, a family member, the clinician, someone at the front desk in the clinic, someone on the phone who's receiving phone calls from a patient. So suspicion of possible cognitive impairment can come up through many channels. And then that should and increasingly does lead to some kind of an assessment. But then there are the next steps. And there are two things I want to point out, really coming from what's in the Q&A and the chat right now. And that is that it doesn't always take a doctor. It certainly doesn't take a specialist in all cases. In fact, most cases arguably may not need to have an actual dementia or brain specialist do the diagnostic evaluation. There are standards for doing this, and it would be a mistake to assume that you always have to see a specialist in order to get a competent diagnosis of a cognitive problem. So that's one. The other is that it's possible to expand the roles of non-licensed workers. Several people in our Q&A have raised the possibility, or actually described what they're doing with community health workers. And we might call these care navigators, we might call them medical assistants, we might call them people who are not clinically licensed as providers. They're not billing providers, but they are ancillary healthcare personnel who can be trained to do dementia detection in a reliable way, and to communicate results to a clinician who can then use that as a launching pad for a further conversation. And then for what matters more than that even, it's, well, what do you do with the information? What is the care plan that you are in, that you now wish to create as a result of what you now understand about the person's cognition? Right. And I want to bring us back to the annual wellness visit, because among the requirements of the wellness visit is that there be some kind of a prevention plan that is shared with the patient. And we know very little about what's actually being done because people are not describing this in the medical literature. We're not hearing about what's happening with those prevention plans. But just for everyone who's here, because we have a really mixed audience today, the next step after detection is further evaluation. And after that, it's care. And those steps happen typically in a sequence of visits, a series of visits, not all in one. And sometimes it happens all in one, but it happens mostly as a planful sequence. And that's where being able to influence your healthcare system about this is what this is. If you are slotted for 10 to 15-minute visits all day long, you're not going to be able to do this as a primary care clinician. You need to have some flexible scheduling, don't you? You need to have opportunities to schedule a follow-up and bring in the family. So would either or both of you like to comment on structuring what happens next and how you influence healthcare systems to embrace this reality?
Well, I thank you for bringing this back around to the annual wellness visit, because I had a couple more comments about the incentives for healthcare systems. So you're right, the preventive care plan is key. And one of our arguments here is that by doing the annual wellness visit, we close the quality measure gaps. and we make them very, very easy to order. So that's number one. Number two, just aside, one of the other incentives is that it's a chance to make sure the problem list is correct so that you can work on your appropriate HCC coding and RAF scoring, which of course, lets the system know how complex your patients are. So yes, and what we've done in practical terms, not only we integrated the annual wellness visit template within Epic into flow sheet rows, which means that we can query it easily, but we also developed an order set accompanying the template. And, we're very clear, whether it's residents or some of our medical students or learners or, who knows, we're very clear. We say, we want you to understand your patient. We want you to go through this template, but you are not here to solve problems in the next 20 minutes. That comes later.
Right.
So we make it, so if we find somebody has cognitive dysfunction, we have a very easy checkbox in the smart order set that says refer for cognitive testing, refer to a health coach, refer to Alzheimer's Association or Alzheimer's OC. So there are next steps built in, and they don't have the burden of having to figure this all out in the middle of an annual wellness visit. That's something, as you mentioned, it's not usually a crisis, so it's very easy to follow up as long as you have continuity of care, and that's why that continuity piece is just absolutely key.
Mhm.
And Dr. Gibbs, this really speaks to this concern that we hear a lot, and it's in the chat about how do I do this as a primary care physician if this is not what I do all the time? And it's that structure that you just described. Dr. Chodos, I wondered if you've had a similar, approach, or you're working towards that as you described with respect to the annual wellness visit or other structures to try to achieve this.
Yeah, I would just echo that. We similarly came up with a template that people can, use and without trying to make it overwhelming, that they can kind of chip away at. I guess the other thing, if you imagine it like an initial diagnosis, or you're just starting to realize there's symptoms, maybe treat it like a more active medical condition in the sense that it's not urgent, but maybe it's active, and you just want to have several visits somewhat, more closer together so you can just chip away at it. I mean, sometimes, it takes me 3 visits to really get to the heart of, getting an advance directive done and really emphasizing that, like, we need to set this up because this is going to be important to protect you in the future. Or, I just want to keep, looks like we can get that, brain scan if that's what's needed in the next month. So I definitely want to see you 2 weeks after that. Like, maybe the solution is just, instead of, treating it like a CHF exacerbation, a new renal failure, I'm going to be seeing you a lot for a little while just so that we get all these things taken care of. And they're not going to feel like these, super medicalized visits. That's actually probably the point, but it's really about having time to talk and just work your way down the checklist. In dementia care aware in our trainings, we kind of try to show that in the cases about how doctors just kind of do a little bit here, a little bit there, and over 4 visits, they kind of get a better picture, and how we're really trying to triangulate what's going on with that person. And actually, time as a diagnostic factor is really helpful. And I think if we build that in and start to build in an expectation that time actually helps us, like, to get one snapshot generally is insufficient and less diagnostically useful anyway. So all those things to maybe help make it fit a little better with what we're working with. We can't really ask people to start having hour-long visits. That's just not going to happen.
Yeah. And Dr. Chodos, one of the comments here was asking about your template, wondering if that is either currently available or going to be available. It's something certainly we could post on our website, and I'm sure you could on yours as well.
Thanks for asking that. We are coming up with a toolkit, and that is going to be, so our program just got off the ground about, a year and a half ago. So we're still getting everything up. And we will have a toolkit, and it'll have like EHR templates. And actually we looked at Dr. Gibbs a lot because her team is like so on the cusp, like has so been on the forefront of doing a wonderful job about making everything integrated in the EHR. So we do plan to include those so people can, you know, cut and paste or use them however they can.
Great.
We totally get that's so important.
And Dr. Gibbs, do you have useful strategies as well that are available to our listeners today or others around the country?
Absolutely. I mean, if anybody would like to consult with, you know, how to integrate the annual wellness visit into Epic and or just that process, feel free to contact us at any point. We have a template. We also have built a smart phrase around the approach that Dr. Chodos has developed for dementia care aware. That's very efficient to use. And her team has really eloquently developed an approach that takes someone through that diagnosis in a very quick manner, and, you know, a fairly easy disclosure then to follow up on later. So that approach for dementia care aware is something that I think would benefit all of our listeners as well.
And we in the center are more than happy to also facilitate disseminating that. It's really terrific.
So we're coming close to being done. I want to mention that in the Q&A, you know, several people have written, you know, it doesn't always take a physician. And so the conversation has been about community health workers, but it's also about speech pathologists and occupational therapists and other professionals in healthcare settings who are capable and valuable in identifying and mapping cognitive disorders, especially in tandem with a physician or a nurse practitioner or PA. So I think that there are a lot of ways of doing this, and I hope that the presentation today has illustrated some of the many ways that one can organize a system for promoting planful detection of cognitive impairment with an eye toward improving care and outcomes for our patients. But I now would like to turn to our panelists and ask, what are the most important takeaways that you want our listeners to take with them today? Start with you, Dr. Chodos.
Thank you. Yes, this was an amazing conversation, and I just really want to thank you guys for facilitating it. And you have such an amazing group of participants. So really just want to say thank you too, as a major takeaway. I think the three things I always think about is early detection actually does matter. There are all these low-hanging fruit around brain health and managing symptoms that we really want to emphasize. This is an active process, and planful detection is active and matters. The other, I think the takeaway that we were talking about earlier is just what brings us to the surface if we're not doing a screening approach, and realizing that behaviors and, you know, more functionally apparent symptoms are really what's bringing it to the forefront. And so having symptoms responsive to that are important in just areas of big need. And then finally, that breaking up everything is really perhaps a feasible way to do it. And I think that really speaks to your team-based approach, which I do feel remiss in not talking enough about. But so little of this has to be that MD or DO, NP, PA, you know, primary care provider. And so I totally agree that a system that's doing it planfully and can find a way to bring in the team has ample opportunity to make this a team effort. Absolutely.
Mm-hmm. Great. Dr. Gibbs.
Yeah, thank you. Yeah, sorry, 3 takeaways.
Takeaways.
Well, you know, also just to acknowledge the work of primary care. And I like the word planfulness, and really being pensive about not trying to tell or force primary care to just adopt something else, right? It's hard work to be a primary care clinician. And, you know, we know since post-COVID, like the inbox messaging is over 150% of what it was. I mean, this is really, you know, has to be done carefully. But I do think that it's in the realm of primary care. I mean, right now, the lifestyle is so important for the prevention and the whole whole person brain health plan, whether it's exercise, community engagement, and all of that. I mean, primary care clinicians are the experts in that. So this definitely fits into the realm of primary care. And also just, I'm getting away from my takeaways, sorry, but I realize as well that, as science develops treatments or possible treatments, primary care clinicians are going to be on the hook for knowing about those, and the patients will be coming in asking, am I a candidate for this? So organically in the scientific community, it's going to push forward, and we need to be prepared to deliver these toolkits and these approaches and everything else. But my quick takeaways, again, I agree, team-based care. I think the annual wellness visit is one successfully to promote this. And again, I think it's just natural to be in the realm of primary care at this point, and agree with your comments about allied health professionals. I mean, if you're a solo practitioner in an office, absolutely, we can use as much help as we can, whether it's a speech therapist, physical therapist, make them part of your team. So I'll stop there, but thank you.
Okay, so
That's really terrific.
it's, I think we're left with some pretty clear guidance from both of you about how to proceed. And
Sue, I think because we do have a few minutes, I wanted to hear from both Dr. Gibbs and Dr. Chodos, if we had a moment. Some people are full on in the primary care realm. Some people are inching toward, and some people have not started. And so if you were advising a primary care clinician to get started, what would be the first thing that you would have them do? How would you have them really get their toes in the water, if you will? Dr. Gibbs?
Good question.
Where do I start?
I would just ask them to add this as a reminder, to ask people about whether they're having any memory issues. I mean, that's just a 15-second question, and if you can keep this on the top of your minds, just like we keep hypertension on the top of our minds, we screen for it all the time, right? Then we will ask a question, and I think, what we've said before is that you don't have to solve everything. This is a process and it takes time. So even if you learn that there may be an issue, you bring the patient back and you take time to do that later. So little bite pieces, right? Little pieces, and we can conquer this.
Great. Dr. Chodos?
For some reason, when you asked that question, it made me think of the practice level, and it made me think, bring it up at a staff meeting. What are we doing for our older adults? Is dementia, what are you guys seeing with dementia? How can we help? And I think there's different places you could start. And I think, screening is a good place to start, because it often is a very, it can be doable and short if you do it right. And it can be very proactive, and it ends up with people who are, mild. And so it's less overwhelming in terms of the next steps. If we're always doing the reactive piece, dementia has this psychological size for us in practice that's huge because it's so overwhelming. But it could be I think if we see the broader spectrum of people living with dementia, we're going to feel less overwhelmed by it and realize that these sort of crisis moments are only part of the whole picture. And I think just wondering about what's the buy-in, what's the overall feeling. Some people don't think it's an issue, and that's obviously not a good place to start from, but at least where you're at too, as you sort of know.
Right. These are both terrific responses, as this has been just a terrific discussion.
Agree. So grateful. This was really, really interesting.
Yes.
Thanks
Thank you for hosting this.
thank you for being with us today. Thanks to all of our participants for their comments and questions in the chat.
Yeah, and we will try to capture these comments, and hopefully we can determine a way to post this on our website as well.
I second that. The comments were amazing. So would love also.
Really great comments. What a great group. Thank you so much. Take care, everybody.